Yesterday we choose to do the dissection and the diagnosis on the left side, so today the right side, which is always the side which is a little bit trickier because of the angulation. So with a 30-degree lens, I'm moving through the vestibule of the nose, approaching the middle meatus, just to get an idea where we are, identify the insertion of the middle turbinate. Above that little darker area is where we had some post-mortem changes. There was an old blood clot. I'm now going to the floor of the nose, identify the inferior turbinate, and there we are. And I slide along the floor of the nose now, here passing a small septal spur and going all the way back into the nasopharynx. We have arrived at the eustachium. We just can see from 11 o'clock into our picture the posterior end of the inferior turbinate, and if I rotate my 30-degree lens now a little bit laterally, we can have a direct view onto the eustachian tube. And if that were a real patient, you would ask him to swallow now, and you could nicely examine the functioning of the eustachian tube. Just to show you that if you're on one side, if you manage to pass on one side into the nasopharynx by simply rotating the scope along its longitudinal axis, you can see here very nicely the eustachian tube on the other side of the patient. I hope you can see that on the monitor. So up there at 2 o'clock you now have the eustachian tube of the other side, and you can evaluate the entire nasopharynx, and here would be the area where we had the adenoids. And now back again with our endoscope, just by rotation, here we see the eustachian tube on the right side of the patient. I reposition my endoscope now and go back the same way we went in, along the floor, inferior turbinate, septal spur, and there we have the insertion of the inferior turbinate. So our next pass once again goes into the nose, approaching the middle meatus, but not diving into the middle meatus, but just trying to bypass the middle turbinate or go a little bit underneath the middle turbinate. And you can see the superior turbinate already very clearly outlined up there. And now I go again to the area of the choana and go up into the spheno-ethmoidal recess. There we are, the area of the spheno-ethmoidal recess, and I try to swing up here and go higher up until we can identify the sphenoid sinus ostium, and there we are looking onto the sphenoid ostium. We have a small bridge of mucus, which again I will try to bypass, and behind that bridge of mucus we see the sphenoid sinus ostium, right up there. The problem is, but I hope you can see that. That now is superior turbinate, and if I look a little bit laterally, which means underneath that superior turbinate, here you can see the opening of a posterior ethmoidal cell draining into the superior meatus. And to the right of that superior turbinate, once again, the way up into the sphenoid sinus. I retract my scope now again, and we go out of the nose again. All these steps so far have been done using a 30-degree lens. And we will stay with the 30-degree lens and now do our third pass, which will take us closer to the middle meatus. So approaching the middle meatus, and you can see that seen from anteriorly. Can I have the delicate spoon to point out, please? From anteriorly, the middle meatus is relatively narrow, and you cannot distinguish too many of its features. But by simply shifting medially a little bit that middle turbinate, not that much that it breaks, you can clearly see now the posterior free margin of the uncinate process coming up here along the tip of my instrument. You see the ethmoidal bulla a little bit behind, and if I push the middle turbinate a little bit wider, medially, you now have nicely the structures. From 7 o'clock to almost 12 o'clock, you see the posterior free margin of the uncinate process. The center of the picture is dominated by the ethmoidal bulla, and if I try to go a little bit medially to the ethmoidal bulla, we're coming to a small cleft. It looks like an opening, which is nothing else but the way through the so-called hiatus semilunaris superioris into the lateral sinus. And if we're lucky in the lateral sinus, we might be able to see the anterior ethmoidal artery. I'm approaching a little bit more, and there we clearly can see our artery swing across the roof of the ethmoid in a small bony canal. Can we hold it for a second? You see the anterior ethmoidal artery swinging across its bony canal, and there we go back. There we have the ethmoidal bulla. There is our middle turbinate. This is the uncinate process. If I touch that here, you have the uncinate process. And if I retract it a little bit, you see nicely the outlines of the hiatus semilunaris. And you note, please, that you do not see anything like a maxillary sinus ostium. If that small curved spoon now is inserted through the hiatus semilunaris, it dives into the ethmoidal infundibulum. You see it disappear. You can see it disappear here behind. And all that hiatus semilunaris leads us up. So between the uncinate and the ethmoidal bulla, through the hiatus, we go into the ethmoidal infundibulum. The maxillary sinus ostium would be located somewhere down here. We will demonstrate that a little bit later. So let's orient ourselves again. Insertion of the turbinate, and we dive underneath that now. We have the uncinate process here. We have the superior insertion of the ethmoidal bulla. We have the way through the hiatus semilunaris superiors into the lateral sinus, where my instrument disappears now. At the roof of that lateral sinus, we have identified the anterior ethmoidal artery. So let's see whether we can get a better look into that area up to the frontal recess. And in this case, it is not possible. We will do so during the dissection. We just can get a glimpse, but I'm not able to tell you whether what we see now is the way into the frontal sinus or whether this is just another blind of one of the ethmoidal cells. So go back and we return our middle turbinate again. I will demonstrate now the other possibility of how to dive in the middle meatus, which is, as the middle meatus is wider posteriorly, you go to the posterior end or near the posterior end of that turbinate and then rotate your way underneath the turbinate, slip underneath the turbinate, and now you're in the middle meatus looking straight onto the ground lamella, and you investigate from the back to the front. So I retract the scope very slowly, and now you see the bulla emerge. You have the well-known structure of the uncinate, and if I go up now, this will lead us to the frontal recess where we could not identify further structures. Once again, medial to the bulla, through the cleft they called the sinus of the turbinate, between the bulla and the middle turbinate, we approach that opening, the hiatus semilunaris superioris, going into the lateral sinus, and there we can see the anterior ethmoidal artery in its bony canal swinging across. So I will remove that scope now and will perform a diagnostic maxillary sinoscopy, for which I will use the trocar sheath. And could you please, or that will not fall off, and perform a maxillary sinoscopy. Mind that camera for the external. So I go in between the roots of number 3 and 4, while laterally after palpating the infraorbital canal, and stay lateral and inferior to that, and now rotate the trocar through. That was a little breakthrough, which should not happen in a real patient. Always be prepared to stop. Retract the trocar sleeve, and now go in again with still the 30-degree lens, still is, and we will dive into because that was a deep frozen head. I hope it thawed away. So, entering the maxillary sinus, oh yeah, there are some nice things we see already. If I point up, here you can see the way to the natural ostium. That's the natural ostium. There are some mucosal folds. The inferior one of this may reflect to one of the lamellas of the bulla, where this inserts to the papyraceous lamina. Up there you can nicely look directly into the ethmoidal infundibulum. This time you do so from inside, and what you see to your right is nothing else but the lateral aspect of the uncinate process. So you have the natural ostium, and I'm going back a little bit to give you a better overall view, and now we go further back. Here we can look up into the maxilloethmoidal angle, and you see some cells shining through. Note the difference in color. It's a little bit bluish. So these are cells in the maxilloethmoidal angle, and this would probably be the area where one would go on into the ethmoid if one does a transmaxillary exenteration of the ethmoid. Well, what else have we got in that sinus? I will rotate my lens now first a little bit to the left, which is laterally, to get a better view of the floor of that orbit, which equals the roof of the sinus. And there we can beautifully see the outline of the infraorbital nerve. During all of its course, it's bulging a little bit into the floor of the sinus. Look how nicely we can see the the infraorbital nerve passing on there. Small mucosal fold next to it. And there we already look almost to the anterior wall of that sinus. Remember, we have a 30-degree lens. So what you see now at about 11 to 12 o'clock is the anterior part of the infraorbital nerve swinging down a little bit. So what you see as 12 o'clock actually is straightforward immediately at the infraorbital foramen. So this is the floor of the orbit with the clearly outlined course of the infraorbital nerve. So rotating the scope back to the medial wall of the sinus, let's see whether we can find any remarkable thing up there. There's nothing of special interest. So we're going back to see the floor of the sinus. So we look to the floor of the sinus, and sometimes you might be able to see some dental roots coming through, but in that case, there's again nothing of specific interest. It's a completely unremarkable sinus. Now going back again, and what appears to be a little bit whitish is nothing else but the Lacrimal Eminence, so it is the bulging of the nasolacrimal duct in the medial wall. And if I rotate my lens again, we there have the maxilloethmoidal recess, and up there we directly look into the ethmoidal infundibulum, the natural ostium of the maxillary sinus. So there's no specific change, no anatomical variant inside that sinus. This would be the area of the posterior fontanelle up there where we have that mucosa shining through a little bit. Okay, I will go out again and now switch over to a 0-degree lens and start with the surgical procedure now. Okay, so we dive into the nose now with the 0-degree lens, bypass all that debris over here, and I will try to start with the surgical procedure. Can I have the sickle scalpel? So, what we would do first is identify the uncinate process. Here clearly we can identify its posterior margin to see over here. And if we're not sure how far anteriorly this uncinate reaches, it's always better to start with a resection relatively far posteriorly, as I will do now, and just cut through the uncinate process. Probably we can go as much anteriorly as up here. Let's try, yes. So this would be the way and the angle how to insert the scalpel, but then immediately turn it down and try to get as acute an angle as possible. Not go too far laterally. This might lead us directly into the orbit. So in a very acute angle, cutting around the uncinate process in an anteriorly convex shape, and now inferiorly, and take that down till the bony insertion of the inferior turbinate, which you see here. So once again, if we fold that over, this was our incision now around the uncinate process, and now we lift what we have cut around or circumcised a little bit medially. And there we see now our uncinate process, which is fused a little bit posteriorly to the middle, to the ethmoidal bulla. So this is the uncinate process. Our sandwich consists of medial mucosal aspect, bone, and a lateral mucosal aspect. And this pouch we have opened now is the ethmoidal infundibulum, which we have entered from back there. See, all the way. If I insert my knife now and come out back there again in front of the ethmoidal bulla, this is the hiatus semilunaris. And all that space, look, it's as deep as the blade of the sickle scalpel is long. So this is the ethmoidal bulla, and in the floor of this we should be able to identify the maxillary sinus ostium. Now, with a pair of straight fixation forceps, I go in and carefully twist loose first the inferior insertion of the uncinate without putting lesion especially to the turbinate area. Leave that and then go up and grasp for the superior attachment of the uncinate and turn that loose as well. And then resect the entire uncinate process, which you can nicely see now in my forceps, and I remove that. So let's get rid of these final remnants of the uncinate process. And usually the vast majority of polyps already would have gone together with these structures. So our situation has changed. Now we have got a wide access to the middle meatus, and we can have a look at the bulla and see that that bulla is fairly large and getting close to the medial aspect here of the middle turbinate. So where's our maxillary sinus ostium? We don't see it. It should be somewhere down there. But we will leave that for a little bit later. Well, I will go back again for the 30-degree lens just to demonstrate the anatomy now that we have taken away the uncinate and see whether there's some change in the accessibility of the frontal recess, which should be there. So 30-degree lens. In again, insertion of the turbinate, ethmoidal bulla, and now let's look up. And there you already get a view onto the frontal recess and into the frontal sinus, just with that simple resection of the uncinate process. And now let's see where our way into the maxillary sinus is. Remember, we resected the uncinate. We're looking onto the bulla, retracting a little bit, and now rotating the 30-degree scope a little bit laterally, and there we got our friend, the maxillary sinus ostium. We have a nice access looking into the maxillary sinus, and I would not touch an ostium of that size. There is no need to do any surgical approach to that once you resected the uncinate. Going out again and switching back to the 0-degree lens. And we'll continue our surgery. I will go with a straight Blakesley forceps, and our next step will be to resect the ethmoidal bulla, because let's assume our patient has diseased ethmoidal bulla, or we know we have to go for the posterior ethmoid anyway. So I identify the bulla, open it, and do so as much. Go on and resect the remnants of the ethmoidal bulla. Carefully doing so. See, this is the so-called bulla lamella, which swings up to reach the skull base, and in the vicinity of which we said we probably will find the anterior ethmoidal artery. And there we are. We have seen it already via the in the lateral sinus. There we have the anterior ethmoidal artery swinging across. We'll carefully nibble these structures away, and there you see the bony canal. Let's go back again to make sure where we are. We have our middle turbinate. Still, it has not been touched. We have opened the so-called lateral sinus now above the bulla, and we clearly can see the so-called ground lamella now. This is the posterior part of the middle meatus, and its roof is the ground lamella, and here it swings up to become integrated into the ethmoid. Let me take away these final remnants of the bulla to outline this ground lamella a little bit better. So there we are. You see, this is not a straight or horizontal plate, but it can have many curves and bulgings depending on the relation of anterior and posterior ethmoidal cells. So if you have to go on to the posterior ethmoid, we should not go on here or even up there. This will lead us straight to the skull base. We should go immediately above that corner where the horizontal course swings up into the more vertical course. So I will go right through here to penetrate very carefully into the posterior ethmoid. It means first, of course, you go into the superior meatus, and then you open posterior ethmoidal cells. So I just make clear, and that's what I would do during surgery, insert the blunt instrument, and then, like preparating, I would spread that open, first have a look, is there a lumen? Yes, there is, and then go on and take the bone away if there is disease. Now we can resect this, as we have identified the lumen, and there's no problem in creating a relative large connection to the posterior ethmoid, and that's what I'm doing now. It will take me a few moments. This is medial, that's where our middle turbinate is. Okay, so we should not take the entire ground lamella down because this supports the middle turbinate and otherwise it might fall off. So let's have a look, and we're apparently looking in a huge, almost singular posterior ethmoidal cell. And remember what we said about this triangularly shaped cell, these onody cells pointing away from you. Remember, we're on the right side, though this is lateral over here, and there we have the apex of the orbit. And if I penetrate here on purpose, which easily is achieved, I will be able to penetrate into the optic nerve. Remember that. I will fold it back, and we come back to that a little bit later. Can I have that spoon, that delicate small spoon? So if we're looking now for the, I will remove the mucosa, which is something you will not do in a real patient. This is only done for demonstration purposes to show you better the structures of the ethmoid. Okay. Can I have the spoon? So, first of all, I must say, of course, we don't know what kind of a posterior ethmoid our patient has and whether he has a sphenoid sinus at all. Only the scan or the X-ray would have told us. So, once again, that's our perforation in the papyriceous lamina at the apex of the orbit. This is onody cell, so never go on in that direction where you believe the sphenoid would be. So, if we have to look for the sphenoid, we should do so as much medially and inferiorly as possible. Here we can already see a cell shining through. I cannot tell you for sure whether this is another posterior ethmoid cell or already the sphenoid. I believe it is the sphenoid because here I can see the posterior ethmoidal vessels swing across. Here's the small one, there's the bigger one. So let's try to press this structure in by going medially and inferiorly. So we open that, and I think I will need the aspirator because that unfortunately still is filled with ice. Once again, that's a deep, fresh frozen head. So this is full of ice. I will try to have a chance to get that around. And maybe you can see the angulation. We do not go up here, but we have swung down a little bit to reach for the sphenoid. Let me see whether this ice will make it. Well, it does. But it's somewhat tricky. Can I have the straightforward Blakesley again? No, hot water would take too long. So I'm going in with the Blakesley and try to remove the ice. Yes, there we go. You can see the crystalline structures of that. What I do now, I widen that a little bit more. Take off the mucosa, maybe it doesn't bite anymore. You have to clean it in between the branches so it can close again. Okay. And I already can nicely see the optic nerve, which I will demonstrate very soon. But let me first finish that cleaning procedure. Can I have the spoon again? Well, and I believe it's difficult to tell now. Are we in the sphenoid already or not? I believe yes. So there's some ice inferiorly. Well, let's see. Well, let's go back for orientation. Middle turbinate, insertion of the turbinate. All the way up, anterior ethmoidal, roof of the ethmoid, posterior ethmoidal vessels. And there now we have our friend, the optic nerve. Can see it clearly bulge in the lateral superior aspect of the sphenoid sinus. Remember once again, this was this triangularly shaped cell which pointed away from it. So I told you don't go in that direction because this will be the ideal place to kill the optic nerve. And this is true. Remember or imagine you would have gone on here, we would have hit directly the optic nerve. This is the optic nerve. I hope that is somewhat clear. Okay, let's get in again. Yeah, once again, the monitor quality I have is not too good. If it's over there, that's okay. So I hope you can see that optic nerve very clearly outlined during its entire course over here. And inferior to the optic, I think this is an excellent situation to demonstrate that. You have the bulging of the carotid artery. And you can even see that this bulging is a little bit reddish or bluish. And this is always an indication that there is almost no bone above that situation. So look at the size of the spoon, and I will try to take away or feel whether there is bone or not. And look what it does without any effort. There is a bone in the sense of the word. Look at that. I don't think this is more than 0.0 something millimeters. See that? An extremely thin bone. So you can't call that dehiscent, but if you would go with any instrument and take a bite in that aspect of the lateral wall of the sphenoid, you probably would easily run through into the cavernous sinus and into the carotid, which now I will do on purpose to demonstrate you the lumen of the internal carotid. So go in there. Oh, look, it even bleeds. Well, it would be probably a little bit more in a real patient. Can I have that upbiting forceps? What happens if you go in with a forceps and think there's a polyp and easily grasp it, and look how easy you can break through into the carotid, and now you can see into the lumen of the internal carotid artery. A rare glimpse. You can directly look into the lumen. Can I have the spoon again? And once again, I would like to outline the relationship of optic nerve, which is here in its entire course here, and carotid. The carotid always sits a little bit inferior and posterior to that and bulges there, and the optic is above. Now I will check how thick that bone is covering the optic, and it isn't much thicker than was the one covering the carotid. See, I can easily scrape that bone away, and probably this minimal procedure would have done it for the optic nerve. So we should always think the optic too can be almost dehiscent, and minimal procedures like this here, you can see the entire nerve now, could kill it already, because actually it's not a nerve here anymore, but a part of the brain. And once again, going back, you see that triangularly shaped cell, Onodi cell, and if you had gone here through the orbital fat, you would have reached the optic nerve even more and with less resistance. So what is this over here? So this is the intersphenoidal septum, apparently coming a little bit over to the right side of the patient. So you see, if you break through that, let's try to. Probably there's ice on the other side. Yeah, but it's melting away. We should not try to remove all these septal walls, because this will go up to the optic nerve and we might create a lesion like that. We will aspirate that a little bit later after it has thawed. So we are still with a 0-degree lens, and we have performed a sphenoethmoidectomy by now. What I will do now is take a 30-degree lens and focus on the skull base, on the roof of the ethmoid, trying to better outline the anterior ethmoidal artery and the way up into the frontal sinus. But all these steps only are necessary if there is disease. These are not routine or steps that are routinely performed on each patient. It usually needs more. Okay, we're approaching the middle meatus, have the insertion of our middle turbinate, and looking up with a 30-degree lens. We see the anterior ethmoidal artery swing across, just beyond that small septum over here, as indicated earlier. Can I have the up biting, the delicate one? Okay, so there's our anterior ethmoidal artery. Once again, that's the dome of the ethmoid. There we have posterior ethmoidal vessels. There we're in the sphenoid already. So we'll take away this septum now here. And I think we will find a very typical situation. There's our anterior ethmoidal artery, a small canal. And now you see a sort of a blind anterior to that artery. This is not the frontal sinus. It's a very typical situation. You have the anterior ethmoidal artery, then the dome of the ethmoid starts to swing up to form the posterior wall of the frontal recess, and anterior to that, we will have the way now into the frontal sinus. Let's see whether this is true. Once again, for your orientation, middle turbinate, insertion, and these were the remnants of the uncinate, and now I grasp up here to free our way into that area. Still trying not to touch that middle turbinate. Well, now you can see clearly. That's the blind. That's the anterior ethmoidal artery. And now we are finding our way up into the frontal sinus. And there you already look up into the frontal sinus. And I will take away this small bony septum here now to get a nicer and better access to that area. And now you can see and look directly into the frontal sinus. You're looking onto the roof of the frontal sinus right here. Do we happen to have a 70-degree lens, a 4 millimeter? These are the yellow-coded ones. So we'll try to give you a view with a 70-degree lens, which should give us even a better access to that area. And usually this is enough even in cases of massive disease, so you don't even need to touch the frontal sinus ostium directly. Okay, this is somewhat tricky to insert as you don't have any straightforward view with that. I hope I can make it. Despite this, we have our 70-degree lens, and this now is a nice view directly into the frontal sinus. You see there's a small supraorbital recess behind. Once again, there's the anterior ethmoidal artery. This was that first blind, and that's the way now up into the frontal sinus. And we have some anterior niches. In that case, probably a superior blind of the ethmoidal infundibulum. Once again, that's the insertion of our turbinate. Could be a start of a Aganasi cell. Let me try the upbiting again, whether I can manage to reach for that Aganasi cell. Insertion of the middle turbinate. Up here. Let me try to take these away. Well, yes, you see these are just blind cells, and that is our way into the frontal, all the way up there. So going back to the 30-degree lens again. So the last thing to do is to check for the maxillary sinus ostium in case this had be diseased. We're with the 30-degree again. We have the insertion of the turbinate. We have the way up to the frontal sinus. We have that here. We can look directly into it. We have that anterior blind. We have the anterior ethmoidal artery. We have the roof of the ethmoid. We have the posterior ethmoidal artery. And we have the sphenoid, which now has filled with thawed ice. And we now look, where is our inferior turbinate? There we are. So where is our maxillary sinus ostium? There still are remnants of the uncinate process. Or into the anterior fontanelle, and have that back biting, into which we will enlarge that ostium now. Once again, with an ostium size of like that, there would be no need to routinely enlarge it. But now I will insert the backbiting forceps for demonstration only and take away remnants of the uncinate process very carefully, not to create a lesion to the nasal lacrimal duct, which is anterior to that. And this, by the way, is a nice technique of resecting remnants of the uncinate if you had not done so with your first incision, like trying here if there's something left of the uncinate. See, as I'm going up. Okay, so now we have a nice view into the maxillary sinus, and we can identify again the cause of the infraorbital in the roof of that sinus. I think you can see that very, very clearly, and can decide whether there's anything that needs to be done. Can I have the backbiting again? So in case we would have an accessory ostium in the posterior fontanelle, we would always try to enlarge that ostium at the expense, that's okay, at the expense, not at the expense, that ostium into that natural ostium to avoid that circulation of mucus, as I've shown you on the slide. So you easily can go in there and then continue with a upbiting forceps to remove that mucosa from up here. See, so you can create a very, very nice and wide ostium. I will not do so further, but there's not routinely any need for that. See, a huge and wide ostium. So what remains to be done? We've performed a total sphenoethmoidectomy without touching the middle turbinate, so you can leave this there. A procedure like this is very, very rare. I will now show you, I think I need the spoon, some of the points of danger. I have shown you the optic nerve. I've shown you the relation to the carotid artery, and we opened that on purpose. Once again, we have our insertion of the middle turbinate, and we have the anterior ethmoidal artery clearly outlined here. We have the posterior, and there is where I created a lesion to the papyraceous lamina and the posterior ethmoid. Look at the dome of the ethmoid. If I palpate here, it is very hard to get through. I will try extremely hard. Now it works. So there is considerable force or power needed to break through superiorly. But this, once again, is a thing very rarely to occur. However, let's look at our anterior ethmoidal artery. Here you can see it very nicely as it swings across from the orbit, roof of the ethmoid, and leaves medially. And if we insert our instrument here, and this is a nicer case, and you can see I'm just holding the instrument with 2 fingers and applying only minimal pressure. And you see it disappears like in soft ice cream. So there's almost no resistance in that area. Once again, we have the anterior ethmoidal artery. This is the insertion of the middle turbinate coming down, so we're well above the cribriform plate. So here we're looking straight into brain, anterior fossa, right up there. See, you can see the brain up there. So this is very easily done. So going up, once again, where's our middle turbinate? There's the insertion. So we did not go straight up, but we turned the instrument a little bit medially, and there the bone offers you least resistance. So this is an area of extreme danger. I will try to outline the anterior ethmoidal artery a little bit better. And there we are. You can nicely see it now. Anterior ethmoidal artery in its bony canal. And there it is extremely thin. So that's an area of danger. The other area of danger is if you look, let me rotate my lens a little bit laterally. If you look to the papyraceous lamina, the area of the ostium, and you palpate for this only a little bit too high, say over here, then you'll be in the upbiting please, in the orbit as well, and you will protrude orbital fat very easily. But as I told you, this is not a problem as long as you do not mistaken this for diseased mucosa. Even an amount like this can carefully be pushed back, not into, but like that, put in a Maricel sponge or a resorbable package, tell your patient not to blow his nose, that's it. Maybe get some air in his lid or a small little bleeding in the canthus, but usually that's not a problem. Of course, if somebody goes on and takes out fat and rectus, medius, rectus muscle and so on, this will mean problems. Finally now, there is one thing which yesterday I have forgotten to demonstrate. I will rotate my endoscope a little bit medially. And can I have the spoon again? So we are looking at the insertion of our middle turbinate. Once again, middle turbinate is here. And remember or imagine you would routinely resect the middle turbinate. What happens? Let's go up here. And do you know these structures here? These are the olfactory fibers. 1, 2, many more back here. So if you resect the turbinate, you inadvertently will open or tear these olfactory fibers. And you know that the dura passes directly on into the perineurium of these fibers. So there will be mini CSF leaks which may seal, but may in one or the other case give rise to a persisting CSF leak or even a meningitis in the consequence. So if ever possible, try to preserve that middle turbinate. I'm looking now up into the olfactory ridge.